Good morning, Professor Mamas. It's lovely that you're able to join us today. Welcome to my kitchen. We're working at home today. Professor Mamas, Professor of Cardiology, consultant cardiologist at the University Hospital of North Midlands. Thanks for taking some time to talk about our Breathlessness and 100,000 Conversations campaign. The campaign is around trying to tackle the stubbornly low awareness of heart valve disease. We know that lots of people, particularly older people, put down the signs and symptoms of breathlessness, tiredness and dizziness to the natural signs of aging. And unfortunately, we don't detect the disease as early as perhaps we should. So we're wanting to develop a campaign where people can talk over the fence in the garden, with the postman, anyone, a loved one, or someone they want to talk to around valve disease and get that conversation going. So it's great that you're here today. One of the things that struck me just recently was a piece of research that you launched, particularly around the pandemic and the impact that it's had on valve patients. I wonder if you could just tell me a little bit about that.
Yes, so thank you for inviting me. I think this is, really important conversations, and I think you guys are doing a really important job in raising awareness for patients with heart valve disease. My group, along with others in the UK, wanted to look at the impact of the COVID pandemic in patients with cardiovascular disease. And one of the patient groups that I think is really important where we look at it is patients with heart valve disorders, particularly critical aortic stenosis. The way we did this was to use national data. So in the UK, every time a patient has a procedure, data is captured and stored about the procedure and about their patient outcomes. And so what we did was analyze data over the past 3 years of patients undergoing procedures for critical aortic stenosis, either through cardiac surgery or through TAVR. And the first thing we noticed was that there was a significant decline in the types of these procedures during the COVID pandemic, which we defined as starting in March 2020. On average, surgical activity reduced by around 80%, whereas TAVI activity reduced around 50%. So taking all this into account, we estimate there's around 50,000 procedures have not been undertaken for patients with critical aortic stenosis. Now, this is really important because you may think, well, okay, 5,000 procedures haven't been undertaken. We can undertake them at a later date. But for conditions such as critical aortic stenosis, this has an impact on patients. And the reason why it has an impact is that we know that particularly in patients on waiting lists for long periods of time, there is an impact in terms of both heart failure, hospitalization, and death. And so really this has started the discussions around, okay, we've quantified this, what do we do about it? How do we overcome this waiting list now of over 5,000 patients waiting for their procedures?
That's incredible, and we saw that played out in the patient voices that we were listening to during the lockdown. We saw disruptions to treatment. We saw patients saying that my procedure had been cancelled or delayed. And we developed a Just Go campaign, the Just Treat Us campaign. We developed resources for those patients, but data is really important to push forward the backlog. And how do you think we can clear some of that backlog?
So I think, I'm very much someone that believes in the power of data. And I always say that data saves lives. And so I think personally that all policy and questions around health should be really driven by data. And so we've done this in collaboration with Newton Maths, which is an institute at the University of Cambridge, where a group of us got together, cardiologists, cardiac surgeons, cardiac anaesthetists, and most important, mathematicians. And they did mathematical modelling, and we sort of gave them, the clinical insight. And really, a couple of things come through. So I think first and foremost, we need to be able to quantify the problem. And I think that's what my group's work has done, quantified the problem of over 5,000 patients now on the waiting list that haven't received surgery or intervention. The second thing that we can do as medics is start to think about prioritization, because if I go to people that do coronary procedures, they're going to say exactly the same thing. If I say the same thing about patients waiting for pacemakers, they're going to say exactly the same thing. So really, we need to sit down, and then that's only within cardiology, let alone, cancer surgery and so forth. So I think we need to sit down and start thinking about, where the priorities lie. And I would say patients with heart valve disease must be close to the top of priorities, because we know that left untreated, patients do have increased events and poor outcomes. Then specifically, what do we do about it? Well, the mathematical modelling suggests that there are two real ways to address this. The first way is change our working patterns. We're not going to get on top of this sticking to 5-day working. We need to move to 7-day working. It's going to mean restructuring of services, but I think it's important, and it's something that needs to be looked at a regional level. The second thing is the balance of procedures that we do. So we know that patients that have aortic valve surgery have very good long-term outcomes, but we also know that they end up having to stay in hospital for many days. And you can get patients through much quicker by doing percutaneous, so TAVI. And so one of our recommendations would be to switch some patients that would be suitable for a TAVI procedure from surgery to TAVI, so that you can then get through the waiting list much quicker. I mean, there's always arguments with surgeons and interventional cardiologists about which is better. Is TAVI better? Is surgery better? But I would say that, either one of them is better than doing nothing or having the patient on a waiting list. And so my view would be that we have to be pragmatic here. We have a real emergency problem here of 5,000 patients on a waiting list that haven't been treated. And really, we need pragmatic solutions with close working between surgeons, interventional cardiologists, in trying to work out how we can deliver, the quickest amount of treatment for the maximum patients.
Absolutely. And at Heart Valve Voice, we say it's about the right treatment for the right patient at the right time.
Yeah, precisely.
That's something that we hold very dear. I just wondered a question around clinic. The campaign 100,000 Conversations is to encourage people to recognise those symptoms and to go and see their GP, primary care specialist, and talk about the disease, perhaps their heart listen to. Those that have been frightened of coming into the NHS and hiding away at home, I just wondered, is that playing out in clinic, in that we're seeing sicker patients in clinic, and that leads to the kind of, we need to get the right treatment to the right patient at the right time?
Yeah, I mean, I think during the pandemic, I think there has been perhaps that the public health messaging hasn't been optimal. So the stay at home, save lives, protect the NHS, that's sort of great in one way, but I think it's been detrimental in other ways. And my group have published several papers showing that during the COVID pandemic, there has been a big spike in cardiovascular death of patients. And we've also recently published a paper around heart failure, and shown there's been excess deaths of heart failure in the community, and some of these patients will have valve disease. So very much, you're absolutely right. Many patients have felt that, staying at home is the right thing to do, and have been ignoring their symptoms. And often, particularly, in patients with heart attacks, I've been seeing patients present really late, and I've been seeing complications that I haven't seen for years. And that's because of the late presentation. And again, patients with valve disease, particularly during the pandemic, have avoided coming to hospital or have left it until their condition has really progressed. And the second thing, which is important, is that many of the investigations that we undertake, like routine imaging, have been delayed. And the reason they've been delayed is because of, number one, we've tried to reduce patient visits to hospitals as a means to protect patients from cross-infection. But number two, a lot of the imaging has been taken up by imaging of inpatients that, where services have been flooded with sick patients with COVID. And I think, going forwards, to my mind, we need to rethink how we deliver more integrated care to patients with heart valve disease and make it more of a one-stop clinic rather than, the current model where a patient comes and sees a consultant like me. I take a history, I listen to their heart sounds. If I think they have valve disease, I then go on and refer them to for imaging. They have that, they wait, I see the result. There's delays in the system, and we need to remove those.
Yeah, exactly. And again, the conversations that we have right across the UK with clinicians, we hear those kind of things resonating back. This has been absolutely wonderful. I could talk to you all day. I think the big learning I've took from this is around how data really needs to be the foundation of changing policy, and that the patient voice can push that through to get it heard by the right people. So I just want to thank you so much. I encourage you to have your 100,000 conversations with someone else. I know your audiences are huge. You can talk to everyone around the clinics, and I just want to say a really big thank you from all the patient community.
I think it's been a real pleasure. And I'd say the final thing that I would say to patients is, if you're getting breathless, if you have blackouts, chest pains, see your GP. This is not a normal part of aging, and that's the common thing that I hear from patients. I noticed my exercise activity has gone down. I've become more breathless. I just thought it was normal aging. No, you're not wasting anyone's time. Go and see your GP. And hopefully they'll listen to your chest through a stethoscope, and it may just impact on your future health.
Wonderful. Thank you very much. Nice to see you.
Thanks.